Welcome to the Deep Dive. Today, we're tackling a really important topic, cerebral palsy.
Mm-hmm.
It affects so many people, but there's often, a lot of complexity, maybe some misunderstandings, especially thinking about wheelchair users.
That's right.
So our goal here is simple. Give you a clear, informative overview. Cut through some of that confusion.
And for this deep dive, we've pulled from quite a range of places. Medical guides like Cerebral Palsy, a complete guide for caregiving, which is really comprehensive. Plus, our own clinical notes, experience from the field, and key stuff from organizations like AACPDM, that's the American Academy for Cerebral Palsy and Developmental Medicine, and the WHO.
So a solid base of information.
Definitely.
Yeah.
And the idea is to boil all that down into something practical, knowledge you can actually use.
Exactly. So we're going to structure this around three main parts, just to keep it clear.
Sounds good.
First, we'll get into the basics, what CP actually is, the fundamentals. Second, we'll talk about best practices for daily care, with a particular focus, as we said, on folks using wheelchairs.
Very important.
And third, we'll walk through navigating the daily routine.
Okay.
The aim is clear insights, actionable stuff, without getting lost in the weeds.
Let's do it.
Okay, let's dive in. Part one, the fundamentals.
Right. So starting with the definition, cerebral palsy, or CP, it's essentially a disorder affecting posture and movement.
Okay.
And crucially, it's described as non-progressive.
Non-progressive, what does that mean exactly?
It means the original injury to the brain, the damage that happened, it doesn't actually get worse over time. And this is but the effects of that injury, how it impacts the person's body and movement, those can definitely change as a child grows and develops.
Right, so the underlying cause is stable, but the symptoms can evolve.
Precisely. And this damage happens to the developing brain, usually before birth or sometimes during the birth process itself.
So it's typically something you're born with or happens very, very early.
That's right. Congenital CP, meaning present from birth, is by far the most common scenario.
Got it.
There's a smaller percentage linked maybe to birth injuries or injuries in very early childhood. But if you see motor problems starting after age 5, it's usually classified differently.
Like what?
Could be seen as maybe a stroke or a traumatic brain injury outcome, something like that, based on our research.
Okay, that clarifies the timing. Now, the causes. You said brain damage, but what leads to that? Is it like one specific event?
Rarely just one thing. It's usually more complex than that.
Okay.
Think multiple risk factors kind of stacking up. And a really big one is premature birth.
Premature birth. How significant is that?
Potentially involved in maybe 40, even 50% of cases, according to some sources.
Wow.
And specifically, very low birth weight. We're talking under about 4.5 pounds. That's linked with a higher risk of bleeding inside the brain, intracranial hemorrhages.
And those bleeds can cause the damage leading to CP.
Exactly. Yeah.
Are there other major causes we should be aware of?
Yes, definitely. Our sources point to a few others. Head injuries, for example, they seem to pop up a bit more often in cases of spastic CP.
Okay.
Then there are conditions like neonatal encephalopathy, basically when a newborn's brain isn't functioning right, or hypoxic ischemic encephalopathy.
That sounds serious.
It is. It means the brain didn't get enough oxygen around birth time. And these seem to be more frequent in quadriplegia, where all 4 limbs are affected.
It's interesting how these different early issues might relate to the type of CP someone develops.
It really is. And, it's worth mentioning some causes that used to be more common, well, they've been nearly wiped out in places with good resources.
Like what? Better medical care?
Yeah, advances in neonatal care, things like that. But with more global travel, new diseases popping up, there's always a small chance some of these could reemerge.
Something to keep an eye on.
And structurally, looking at the brain itself, problems are often seen in the white matter.
Connections.
Exactly, the tissue that helps different brain areas talk to each other. That's seen in maybe 80% of cases. And the thinking is, over 3/4 of these issues likely start during pregnancy.
So often traceable back to development in the womb.
Often, yeah. Sometimes imaging, like an MRI, might show, brain malformations or evidence of a stroke that happened before birth, or maybe hydrocephalus, that's fluid buildup.
Right.
But it's also key to know, normal brain scan doesn't completely rule things out. The problem might be more functional at the nerve connection level.
Okay, so it's complex. We have the what, some of the why. Now, how is CP classified? You mentioned spastic, quadriplegia. There seem to be different types.
There are. Classification usually hinges on the main type of movement problem someone has.
Makes sense.
So spastic CP is the most common. That's characterized by stiff muscles. The medical term is hypertonia, basically. Muscle tone is too high.
Okay, stiff muscles. What else?
Then there's dyskinetic CP.
Hmm.
This involves involuntary movements. They can look kind of writhing or twisting, sometimes called athetoid or dystonic movements.
So less control over movement.
Right. And ataxic CP is about poor coordination and balance. Often comes with tremors, maybe reduced muscle tone.
Yeah.
This type is usually linked to damage in the cerebellum.
The part of the brain for coordination.
Exactly. And sometimes you see a mix. Mixed CP is when someone has features of more than one type.
Spastic and dyskinetic, maybe?
Could be, yeah.
Mm.
And one more we should mention, though less common, about 2.6%, is hypotonic CP, or atonic. That's the opposite of spasticity. Very low muscle tone, making the muscles feel floppy.
Floppy muscles. Wow, quite a range.
It really is. And understanding these types is crucial because it guides therapy, right? Someone with dyskinesia needs a different focus than someone managing spasticity.
Definitely not one size fits all. And all these types must impact posture and muscle tone significantly, especially for wheelchair users.
Hugely. Abnormal muscle tone too high or too low is central, and managing posture is key.
How so?
Well, that spasticity or the involuntary movements, they can literally pull the body into stiff or twisted positions.
That sounds uncomfortable and potentially harmful.
It can be. And just sitting for long periods in a wheelchair, if it doesn't have the right support, that can actually make muscle tightness worse over time.
So the seating itself is part of the management.
Absolutely critical. Adaptive seating helps maintain alignment, can reduce that abnormal tone, even prevent deformities from developing or getting worse. Good alignment can even make breathing and swallowing easier.
That really links back to everything. Which brings us to complications. It sounds like CP is often more than just the movement disorder itself.
That's very true. There are often associated medical issues and complications. Seizures are a big one.
Right, epilepsy.
Yeah, quite common. You have generalized seizures affecting the whole brain, like tonic, clonic, absence seizures, others, and focal seizures starting in one area.
Can they be treated?
They're generally not curable, but they can often be managed pretty effectively. With medication, sometimes special diets, nerve or brain stimulation. Surgery is an option too, but usually only for really severe, tough-to-treat epilepsy.
Okay, good to know management is often possible. What other kinds of associated problems might someone encounter?
Well, our sources list quite a few possibilities. Things like intellectual disability, learning disabilities, ADHD can co-occur.
Okay.
Hydrocephalus, that fluid buildup we mentioned. Sometimes self-injurious behaviors can be a challenge. Visual and hearing impairments are also more common, often linked back to those same risk factors like prematurity.
So hearing loss.
Can be conductive maybe from frequent ear infections, otitis media or sensorineural, affecting the inner ear or nerve, or sometimes a mix.
Right.
Feeding and swallowing difficulties are very common too. This raises the risk of aspiration food or liquid going down the wrong way into the lungs.
Which can lead to pneumonia.
Exactly. So sometimes feeding tubes like G-tubes or J-tubes become necessary just to ensure safety and get enough nutrition.
Makes sense.
Gastroesophageal reflux, or GER, is common too. Acid reflux, basically. Then you might see issues like low bone density, higher fracture risk, especially with less mobility. Dental problems like gum overgrowth, hernias. For boys, undescended testicles can be more common, especially with spastic CP and prematurity.
Wow.
Neurogenic bladder, nerve-related bladder control issues, and nystagmus, those jerky eye movements.
Oh, it's quite a list.
Yeah.
It really shows how CP can impact so many different body systems.
Yeah.
What about sensory issues, touch, pain?
Absolutely. Sensory deficits are common. People might be hypersensitive, overly sensitive to touch, sound, etc., or hyposensitive with reduced sensation.
How does that play out?
Well, think about it. If touch feels unpleasant or overwhelming, a child might be hesitant to explore things with their hands, right? Which could then impact developing fine motor skills. It's all interconnected.
Yeah, I can see that. And orthopedic problems, issues with bones and joints.
Yes, frequently seen. Scoliosis curvature of the spine is a risk, and it can worsen during growth spurts in adolescence. Hip problems are another big one. The hip joint might partially dislocate that subluxation or fully dislocate. This is more common in quadriplegia and dyskinetic CP.
Right.
Limb contractures, where muscles get really tight and restrict joint movement. Think tight hamstrings, hip flexors, or the muscles that pull the legs together.
Limiting range of motion.
Exactly. And foot deformities, too. Flat feet, maybe toe walking because of a tight Achilles tendon, or feet turning inward or outward equinovarus or equinovalgus. And again, puberty growth spurts can sometimes make walking harder for those who already deal with high muscle tone.
This really underscores the complexity. Okay, let's shift gears into our second section. Best practices for care. Given everything we've just discussed, where do you start with daily care for a wheelchair user with CP?
Safety. That's always number one. Safety for the person with CP and safety for the caregiver.
Makes sense, like with transfers, moving someone.
Absolutely. Transfers bed to chair, chair to toilet, whatever it is, need proper technique. Our sources really stress using assistive aids when needed.
What kind of aids?
Things like gait belts, sturdy belts around the waist for grip, sliding boards to bridge gaps, or even mechanical lifts for heavier transfers or when it's safer.
Okay.
And for the caregiver, proper body mechanics are just non-negotiable. Keep your back straight, bend your knees, hold the person close, prevents injuries.
Crucial advice.
And always, always check the path is clear and lock those wheelchair brakes before you start moving someone.
Simple steps, but so important. What about basic hygiene bathing, dressing?
The key there is finding the right balance between safety and promoting independence, whatever level is possible for that individual. For bathing, again, safe transfer techniques are essential, plus any adaptive equipment needed, shower chairs, grab bars, etc., and thorough skincare. Cleaning and drying really well, especially in skin folds, helps prevent skin breakdown and infections.
And oral hygiene.
Also vital. Regular brushing and dental care are really important, especially since some medications or feeding issues can affect oral health.
Good point. Now, feeding. You mentioned difficulties earlier. How do you manage that safely?
Yeah, challenges with sucking, swallowing, chewing, self-feeding are definitely common. It stems from the motor and sensory issues, maybe balance problems, lack of coordination.
So what's the approach?
Prioritizing safe swallowing is key. This often means modifying food textures, making things softer, pureed, or thickened liquids. And positioning is huge.
How so?
Making sure the person is seated upright, well supported, often in their adaptive chair during meals. This reduces the risk of aspiration.
That risk of food going into the lungs.
Exactly. Which, as we said, can lead to pneumonia. And remembering that reflux, GER, is common, so positioning helps with that too.
Okay.
And it's interesting, often the fine motor skills needed for using a fork or spoon are more impacted than bigger, gross motor movements. And generally, feeding difficulties tend to be more significant for individuals with higher GMFCS levels, meaning more severe motor limitations.
So tailored food, careful positioning. Got it.
Hmm.
Now, mobility for wheelchair users. What are the best practices there?
Well, the wheelchair itself is paramount. It's not just transport, it's therapeutic.
How do you mean?
Choosing the right chair manual, powered maybe tilt in space, which allows repositioning without changing hip knee angles, is crucial for posture, pressure relief to protect the skin, and overall function.
So getting the right fit and features is key.
Absolutely. And then there's physiotherapy. Ongoing physio is essential for stretching tight muscles, strengthening where possible, and just maintaining joint range of motion.
Keeping things moving.
Exactly. For some, standing frames can be beneficial, good for bone density, circulation, stretching. Walking aids might be used, if appropriate.
What about those baby walkers, sling seat types?
Yeah. There's some debate there. Some parents like them, but many therapists worry they might encourage poor movement patterns.
Is there proof they're harmful?
Not definitive proof of long-term harm if used carefully supervised away from stairs, stable, but the concern about movement patterns is valid.
Okay, something to discuss with a therapist.
Definitely. And overall, regular exercise adapted to the person's abilities is so important. Prevents deconditioning, boosts mood, general well-being.
Makes sense. Now, what about communication, especially for those who are nonverbal?
AAC, augmentative and alternative communication, is vital.
AAC.
Yeah, it's a broad term for tools and strategies that help someone communicate without speaking. Could be picture boards, eye gaze systems, speech-generating devices, lots of options.
Giving people a voice.
Exactly. And beyond communication tools, we have to remember the emotional and social side.
How so?
Individuals with CP have the same needs for relationships, connection, intimacy, self-expression as anyone else. Caregivers play a huge role in supporting that.
Encouraging social interaction.
Yes, creating opportunities to connect with peers, fostering a positive self-image, recognizing that CP might impact things like self-control or social skills sometimes, and providing support there.
Looking at the whole person.
Absolutely, which leads us to the caregivers themselves.
Right. Caregiver self-care. Hugely important, often overlooked.
It is. While our main care guides focus on the person with CP, the reality is providing this level of care, especially for someone with complex needs, is incredibly demanding, physically, emotionally.
It takes a toll.
It really can. So caregivers need to prioritize their own well-being, seeking support, finding resources. It's not selfish, it's essential for sustainable care.
Support groups, respite care.
Exactly. Connecting with others who get it, taking breaks, it's crucial to avoid burnout.
Couldn't agree more. Okay, let's move into our final section, the daily routine. How do you structure a day to support quality of life and manage everything we talked about?
Structure's good, it provides predictability, but it also needs to be flexible, Life happens. The goal is quality of life, preventing complications.
So a typical morning, what does that involve?
Usually starts with personal care, dressing, washing, toileting assistance as needed. Important to think about positioning right from waking up, administering any morning medications, and then just getting ready for the day's activities, school, work, therapy, whatever's planned.
And therapy sessions often fit in there somewhere.
Yes. Integrating prescribed therapies, physio, occupational therapy, OT. Speech therapy is usually part of the routine.
Oh, often.
It really varies. Depends on the person's needs, their response, what resources are available. But that period, maybe age 4 through the start of school, is often seen as a key window for intensive therapy.
Right.
And a key point here, therapy should ideally be a positive experience. The parent or caregiver is there for support, encouragement, not just to be the therapist 24/7.
Maintaining that parent-child relationship.
Exactly.
What about getting out and about? Social and community engagement.
Super important. Actively planning accessible outings, parks, museums, visiting friends. That means thinking ahead about transport, building access.
Logistics.
Yeah, lots of logistics sometimes. And working with schools or workplaces to make sure necessary accommodations are in place. Ramps, accessible restrooms, maybe communication supports.
So enabling participation.
Absolutely. And facilitating social skill development, maybe through group activities or peer programs, can make a huge difference.
Okay, so that covers the day. What about the evening and nighttime routine?
Evening often includes the evening meal, again, paying attention to safe swallowing, good positioning,
Right.
any evening medications. Maybe the bathing washing routine happens then, using those safe transfer and positioning methods we talked about.
Clean and dry skin.
Especially in folds, yeah. Completing oral hygiene. And then nighttime positioning becomes really critical.
We touched on this, but why is it so important at night?
Several reasons. One is preventing pressure injuries, bed sores, using supportive mattresses or overlays and sometimes needing repositioning schedules to minimize pressure on bony spots.
Okay.
2, comfort and sleep quality. Being in a stable, comfortable position helps sleep.
Makes sense.
3, managing muscle tone and preventing contractures. Certain positions, maybe using pillows, wedges, or special sleep systems, can provide a gentle, sustained stretch to tight muscles.
Like holding a stretch while sleeping.
Kind of, yeah. Supporting limbs in good alignment, aiming for symmetry as much as possible.
Got it.
And also just thinking about thermal comfort, not getting too hot or cold.
So nighttime positioning is quite an active part of care, not just letting someone sleep, however.
For many, yes. It's preventative care, and linked to that is good general sleep hygiene.
Like a consistent bedtime routine.
Exactly. Relaxing routine, a good sleep environment, dark, quiet, comfortable temperature, and being aware of things that disrupt sleep, which are common with CP.
Such as?
Pain, nighttime seizures, breathing problems like sleep apnea, reflux bothering them when lying down, maybe just needing to be repositioned.
Lots of potential disruption.
There can be. Addressing those underlying issues is key. Sometimes, if sleep problems are persistent, a specialist might discuss trying melatonin or refer to a sleep clinic.
Right. A whole area in itself. This has been incredibly comprehensive. As we wrap up, what are the absolute key takeaways you want people to hold on to?
I think number 1, managing CP and providing good wheelchair care takes a really holistic view and consistent effort. It touches everything. Number 2, remember the huge variability. CP is different for everyone, so care must be individualized. No cookie-cutter approaches.
Very true.
And number 3, it really takes a village. A collaborative team approach is essential.
Who's on the team?
Doctors, developmental pediatricians, neurologists, orthopedists, physiatrists, therapists, PT, OT, speech, educators, support systems, and critically, the caregiver, who often ends up being the main coordinator and advocate, Sometimes case managers can help pull services together, too.
It's a big network.
It often needs to be.
And it sounds like, while it's complex and demanding, there is support and progress happening.
Absolutely. There's no cure for CP right now, but research is ongoing. Treatments, technology, supportive care, they're constantly improving. The focus is always on enhancing quality of life, promoting independence as much as possible.
That's hopeful.
It is, and we really encourage you, if you want to learn more, check out resources from organizations like the AACPDM or WHO. They have great information.
Good places to start.
And one more thing, consider seeking out books or blogs written by people with cerebral palsy. Their lived experience offers insights you just can't get anywhere else.
That's a fantastic point. Hearing directly from those living with CP. Thank you so much for walking us through all of this today. It's been incredibly insightful.
My pleasure. It's